So now I'd like to introduce our speakers who are going to talk to us about navigating the U.S. healthcare system. We have Gary Pearson sitting right here. Gary is a St. James resident. He moved here about 4 years ago and began serving our community through his home care agency, No Place Like Home Caregivers. Gary is a licensed marriage and physical therapist who has owned and managed home care for more than 10 years. During this time, he recognized the frustration and anxiety of clients struggling to navigate the maze of the healthcare system. 2 years ago, he connected with Jan West, who is also our speaker today, and she provides a navigation expertise and advocacy for people here at St. James. Jan, who is also sitting next to Gary, is a resident of St. James. So I think it's really wonderful that we are able to, through the series, able to promote people that live here in St. James. She's an experienced and accomplished care manager during her 50-year career, first as a cardiac intensive care nurse in Massachusetts. She's held numerous roles as hospital and regional directors of care management before she moved to St. James. In her positions, Jan played several integral roles on providing care management for healthcare delivery systems, and she's been a key contributor on multiple care management projects. And she's recognized for her expertise in aligning healthcare management strategies with the organization's quality care initiatives and also financial goals. And Jan is going to talk to us today about some of her care management strategies and successes that she's had as she works in the area. So please, let's welcome first Gary and then Jan to our next presentation. Thank you. You're not going to use this, right? You're going to use...
Yeah, thanks.
Does this turn off?
Well, thank you, Linda. As Linda said, Jan has had decades of experience in healthcare management, in patient care management. And so she'll be the key part of the presentation today. My role is just to set up and have us think about what the complexity of the healthcare system looks like and what it means for us. I got involved in the healthcare industry when I was 18. I was a nurse assistant at a VA hospital in Australia, and I was dealing with First World War veterans suffering with tuberculosis. It led me to a series of checkered career that finally brought me to the home care business, which I've been involved in now for over 10 years. The federal government estimates that we, people over 65, 70% of us will be requiring critical medical care before we die. The AARP tells us that 90% of us want to stay at home. The confluence of those two currents creates a convergence zone where there's turmoil both cognitively and emotionally. It takes knowledge and expertise to be able to navigate that sea of turmoil. We can acquire that knowledge or we can purchase it. Our goal here today is to give you some information so that you can navigate that difficult area, whether you do it yourself by acquiring the knowledge or whether you find people like Jan, and there are many of them out there in the marketplace who can help guide you through the system. We use experts for all sorts of things. Something goes wrong with our car, we get an expert to fix it. Something goes wrong with our plumbing at home, we get an expert to fix it. And yet many people are hesitant to look for experts to help them through the healthcare system. There's no doubt the system's complex. Most of us here have spent time in our lives taking care of our own health. How many people have been caregivers for family members? How many people have volunteered, say for Nest or Dosha Hospital? How many of you have volunteered for care organizations? Yeah, many of you. How many have used agencies to help you? Home care agency, home health care agency. There's some confusion between those two. A home care agency takes care of the assistive care needs. The homemaker companion, some of the work that Nest volunteers will do for you. They will help with the personal care as well. The bathing, the dressing, the toileting, that Nest volunteers are not able to do. But then the next level is the home health care agency, where there's skilled providers, nurses, occupational therapists, speech therapists, who are able to take you to a level of care that home care agencies can't do. And of course, then there are hospice agencies as well. The next level are the professionals. The doctors, the nurses, the OTs, the PTs, therapists of all kind, or the care facilities. There's a salad list of care facilities. What about supplies? Where do you get the disposables? What if you need a hospital bed? What if you need a Hoyer lift? Where do you get those from? And how do you pay for it? Not only is the system complex, it's expensive. Maybe it's self-pay, maybe it's your medical insurance, maybe it's a government service. And again, people get confused between what will Medicare pay for and when would I be eligible for Medicaid? Questions that people like Jan can help answer for you. It's easy when your needs are simple. You have your primary care doctor, Medicare, and your personal medical insurance, supplemental insurance can pay for that. That's easy to navigate. But when it starts to get complex, how do you navigate that? How do you know where to go, who to talk to? What facility should I be looking at? Should I be looking at assisted living? Should I be looking at a skilled nursing facility? All questions that at some point in time we may have to answer, or we may have to find somebody who can help us answer. The real point is we should manage those things we can manage, and we should seek support for those things we can't. Don't be afraid to ask for help. Know where to find a nurse navigator, an advocate, to be able to help you through the system. To get assistance in choosing the healthcare service that you're going to use, advocating for what's appropriate and what are you entitled to. And then the funding. Where can you get that funding? What sources are available? What are you entitled to? How do you manage those funds? It's those questions that Sue, who runs a team of people that has over 60 years experience in patient care management, they can help. Here's a simple case study of a client, an ex-client, an 82-year-old male who was 230 pounds or more. He fell while trying to get out of bed and stand up. Broke his femur, a spiral fracture, dislocated his hip, and had to have surgery. When he was discharged from that surgery, he was discharged to go to assisted living with a prognosis of not being non-mobile. Jan was asked to help. She did an assessment of the discharge plan of care. She saw that returning to assisted living was what was being recommended. There was no PT planned, and that the client's long-term care insurance was going to have to pay for it. When she did her assessment, put together a plan of action, she had the rehab reestablished. She had skilled nursing facility, which the client was entitled to, introduced into that plan of care. And Medicare ended up funding it, not the client's long-term care insurance. That saved the client in their long-term care insurance, which you know has a limit. It saved that client $7,000 a month in the reduction of their long-term care insurance. So the results can be dramatic when somebody who really knows the system and knows how to navigate it can help you do that. So putting this theory, this description of the complexity of the system into practice is what I'd like Jan to come up and talk a bit about. We do want this to be your session, so please, at the end, don't hesitate to ask questions at any level. Jan, thank you.
Great. Thank you, Gary. Everybody hear me? All right, great, great. I guess I'm not as loud as I thought. That's not what my family says, though. Well, listen, it's a pleasure to be here. I am real excited to be here because I really see now and over the years what a demand there is and a need there is for families caring for loved ones with a catastrophic diagnosis, terminal illness. It might have creeped up on you. You are stressed out with, what's going on, and you're, going through doctors, hospitals, rehab, whatever it is. So I've seen it time and time again that it's the stress that really is impacts negatively on the families, and let alone the client as well. So like Gary said, there's a couple of things I wanted to underscore what he said quite well, which was around advocacy. As Gary said, I've been a nurse for several years, and my career, clinical career, was in critical care and emergency department nursing. And then I spent the rest of my career doing case management on the hospital in the managed care side. So especially on the managed care side, I was able to learn a heck of a lot about benefits, appropriation of benefits, entitlements, federal government benefit for Medicare. Currently, I'm in my retirement job. What I'm doing is I'm working with Medicaid beneficiaries a couple of days a week in assisting them to stay at home. And there are special programs. They're both Medicare and Medicaid. If you are Medicaid eligible, you have a benefit which would allow you to receive services in the home in order for you to decrease the risk of going in a controlled setting, whether it's long-term care, skilled nursing facility. There's all kinds of names for it. But the bottom line is we want to stay home, okay? As much as we can. So what does that take? Gary has touched upon it and has said, again, advocacy. There are two unfortunate disparities between Medicare and managed Medicare. Now, I'm not going to go too into it except to say, unfortunately, it isn't equitable. What I have found over the years is, particularly with the managed care products, is you really do have to advocate hard. And you have to be able to know the right questions to ask. And that's my favorite part, is to work with clients when they are getting pushback for particularly needed services in order to keep a loved one at home. Now, a few examples that I can share with you where that's really come into play is clients with dementia, neurodegenerative disorders like Parkinson's disease, and stroke, okay? So Medicare, whether you have managed care or traditional Medicare, will cover your care in a hospital, right? Then, depending upon what the deficits are after you recover, for the reason you went into the hospital, you may go into an acute rehabilitation center or a skilled nursing facility. But that's only for a temporary part of time. And usually when you go home, you need continued services. So if you're not able to get skilled services through your insurance company, that's when an agency like No Place Like Home Caregivers can step in and provide that custodial level of care, bathing, housekeeping duties, that sort of thing. But I think what I have really seen an advantage of is being able to interface with the client, with the providers, because there's questions that the clients have, with the insurance companies. I do a lot of that. And what when I get involved, if I'm invited to get involved, what we do is ask you to sign an authorization to represent. In other words, because of HIPAA, I just can't call a doctor for you and expect that they're going to talk to me about what I see in the home, what we're recognizing. So that form is very important. Gary takes care of all that paperwork. No. So he does all that. But that'll allow me to speak to your care providers that you're dealing with. I've gone into skilled nursing facilities. I've had team meetings with the directors of nursing, social work, physical therapy. And with that, understanding what the treatment plan is, and in my assessment, if the patient is getting what they need, okay? And oftentimes I found that it wasn't. There's a lot of perverse reasons for that, okay? When you go into a skilled nursing facility, for example, at a skilled level, you're expected, or your loved one's expected, to have skilled therapies 5 days a week, okay? I've often found that that doesn't happen, okay? So, what I keep an eye on behalf of the client, are they getting the services that they're entitled to, which Gary had touched upon? Are we maximizing the benefit? So that's, a challenge that I would not expect any of you to understand how to do, particularly when you have to call up the insurance company and advocate for the client because they've denied a service, like continued care in a skilled nursing facility. I love that one. Oh, she's okay, she can go home now. No, she's not making progress. Or what about the leg wound? Or, so once they hear me, and know that I am an approved, authorized advocate, funny how things change, really. So one of my clients called me a bulldog. And I said, oh, don't say that, it's not nice. I'm trying to be professional. I know my work. I know what you're entitled to. And I will go after what you should be having. It is just a pet peeve of mine to see what's going on in the country right now and to see that it's us, the consumers of health care, that are really not getting what we're paying for, bottom line. In many instances, I'm not saying always. And again, I will underscore, unfortunately, there is a disparity between your traditional federal Medicare and some of the managed care plans. Now, I don't know if there's anybody in the audience that sells Aetna Medicare. My apologies, but actually it's just my opinion on what I've experienced over the years. So it's not that myself and my team would go after traditional Medicare, because it isn't as challenging. There's rules to be followed, and basically you have to have a medical necessity to get certain services. So when Gary talks about the complexity of the healthcare system, you bet it is, okay? And it's gotten worse. And I expect that it won't get any better. Now, I've said to Gary, I know folks are out there and probably suffering silently, okay? It's always my pleasure to be able to go out, get a phone call, pick up the phone, either go meet somebody and talk to them or talk to them on the telephone. I can get a pretty good idea fairly quickly if they need the support from care coordination. Now, when we talk about care management, care coordination, it's basically, as Gary had pointed out, the interface between the service providers, the insurance company, but the patient being in the center, okay? And you want someone to pull that all together, because, boy, is it overwhelming. And I've seen people get very overwhelmed. Well, what am I going to do? My wife fell. She's got some dementia. She broke her hip. She went to the hospital. She actually got worse when she was in the hospital. She got more confused. And then they wanted to send her to the skilled nursing facility. Okay, everything's getting covered. She's gone to the skilled nursing facility, and they want to clear her and send her home, but she's just not quite there. She's got a lot more needs. She needs more equipment, and maybe I unable to do it, because we forget about the caregiver. And that's really one thing I focus on, is caring for the caregiver, okay? I've done it myself with my mom, may she rest in peace, when she had dementia. I brought her down from Massachusetts down to North Carolina. I was living in River Landing at the time, another community, and I got and coordinated her to stay at a skilled nursing facility, maybe about 10 minutes away from where I lived. And so what I had to do, because it was a nursing home and she was there for long term, is to be able to have a visual presence. And that's another thing I do, is I will have a visual presence, particularly if your loved one is in a facility for rehab, or and the intention is to go home. We really want to get them as strong as possible and capitalize on all the services. So I was there. I had, my husband and I were visible every day. So it got to the point, because I would call team meetings, and just if I saw something that just really wasn't working, I'd request a team meeting, which I am entitled to, as you all are, to sit down and talk with the different disciplines about the plan of care. So it got to the point where I would come through the front door and you'd see them going the other way. So my nickname is not because of a lack of professionalism at all, but it's a matter of motivation and advocacy, and strong advocacy. I believe in it wholeheartedly, because I've seen too many failures in the system, people falling through the cracks because the right questions weren't asked. I've had that as well. So it's not just a matter of the services, but it's a matter of really making sure that you or your loved one is getting everything they possibly can get in order to stay safely at home. Okay? Same kind of scenarios. I've had patients with stroke, okay? And even in my current work for the Medicaid, Medicare beneficiaries for North Carolina, I see a lot of clients, beneficiaries, have these catastrophic strokes, but they don't want to go into a long-term care facility. So what do? Okay? So I'm part of a team that will come up with some solutions in order for them to safely remain in the home. And that might mean going to their managed care coverage, because it also applies to Medicaid. Medicaid is mostly managed Medicaid in the state of North Carolina. So we can't get away from the managed care providers. It's really something that is probably most of us do have to deal with. So we best understand what we're entitled to, and to have someone advocate for us if we needed it. So I think that, in general, I have seen, the other part I wanted to mention is I do a lot of work around appealing denials. Now, I don't know if anyone has ever experienced a denial from your insurance company, but it can be very devastating. Okay? No, we're not going to cover that. Well, let's see about that, okay? So that takes a lot of digging on my part, in my knowledge, to understand, that the care perhaps is skilled, and there's no reason for the denial. So I've had a lot of years' experience getting denials overturned, so that it's not at all coming out of your pocket, that it is the insurance company that is going to cover it, okay? And Medicare's got some pretty strict rules. So even if you do have a managed Medicare plan, your managed care Medicare company is required, mandated, to follow the same rules as traditional Medicare. And believe me, I've seen them try not to do that, or make up their own rules. They cannot under-provide you with the services as if you were traditional Medicare, okay? So that's a biggie, and a lot of folks I've gotten calls for with that. But as Gary mentioned, it's not only putting services in place, whether you're in the home, whether I'm advocating to allow additional continued stay at a skilled nursing facility. It's really a matter of making sure your insurance company pays for it. Okay? Now, there are times where it isn't medically necessary, but I will capitalize on all aspects of the care in order for the company, your insurance, to be able to pay for the coverage. One of my favorite, as I just previously mentioned, one of my favorite passionate things I do is to provide support for the caregiver, because there's a whole host of emotions that Gary had touched on that a caregiver has to go through. Very difficult. The fatigue, the strain, the isolation. Am I doing the right thing? It's very overwhelming. And what we don't want to do is to have people feel alone. I know there's many people out there that are going through some of these issues. And you don't have to do it alone, is basically what we're trying to say today, okay? I think I pretty much, yep, I covered the denials too. Anything else you want me to touch on, Gary?
If somebody in the audience wanted to follow the process of engaging somebody like you, how would they go about it?
Well, Gary and I work with Gary, so I'm available if he got a referral, or even if he's involved with a client and he sees some opportunity. He will call me and he will ask me to reach out to the client or the significant other, okay? And I've done that many, many times, okay? So I would ask you to call Gary's office directly. If Gary's involved, whether Gary's involved or not involved, I still could certainly take a referral. It would start with a phone call, just a phone call. and to talk about the medical status, what's going on at home, the whole history, so I can get an idea of what you or your loved one is going through, what you're going through. And then from there, I would give some recommendations on what the next steps would be. I could identify a lot in a phone call, or I would even come to you if a phone call wasn't feasible. Okay?
So if somebody then did engage services like yours, what would be the next step and what would be the cost?
Well, I have purposely, as Gary pointed out, there are a lot of agencies out there. They're called private care management agencies, and they go upwards of $100 an hour. I don't believe in that. I'm more passionate about getting the word out and being involved, okay? So we're looking at about, 50% of that. And what Gary and I have discussed many times, this is, Gary, I'm retired. I'm not worrying about breaking the bank. I am so passionate about this. I want to get out there. I want to be able to reach people and let them know they don't have to be alone going through a catastrophic illness living situation. So we're able to slide the fee schedule if necessary. So we would never turn anyone away. But Gary I would ask Gary he would handle all of that. He does all of the, interaction with the clients. And I think sometimes what we have found is that if you're already involved with private caregiver support with Gary, let's say, or any other agency, and you're paying out of pocket, it becomes difficult to think about, another expense. So we are willing to negotiate and talk and work something out. So nothing is etched in stone. I prefer that it not be that way. Not that I can handle 150 patients, but sometimes it's a couple of phone calls. You don't need me on a long term. Maybe it's a week, of being involved. What I do right now, and Gary and I have really put our heads together to try to make this doable for folks, is that if there was a real complex situation, and I'll let you know that when we talk, and I knew that I was going to have to do a lot of front-end work with you and your loved one, for about 4 weeks. Maybe in the beginning it would be 4 days a week. Maybe the third week would be 3 days a week. But over the course of a month, what we decided to do is to bundle that to $150 for the month. Now, I could go out every day, I could go out 2 days, but usually I can pretty much figure out within 4 weeks what needs to be done. If you needed more care management support on a longer-term basis, then the fee schedule would be per visit, okay? And that would be where the 50 would come in, $50 an hour. As I said, it's not necessarily forever, long-term, because things can settle down. But it might be you want me involved in locating a long-term care facility. I've done a lot of that. Trying to find someplace, especially down here, with the quality of care, okay, is very worrisome. But on that note, if, let's say, we together found this facility, what I would encourage, which I do, is an ongoing assessment. So in other words, just like I did with my mom, I'd be walking in. I'd have permission to talk to you because the client appointed me as their representative, just like an attorney, okay? And I would call for a team meeting. I've done that many times, to be able to talk about the plan of care and what is going on, and what are the lab tests? Well, why is she feeling so fatigued? When's the last time she had her CBC panel done. So I could, I'm interfacing with the clinicians and the PTs and what kind of progress is she making. So frankly, it's just questions that a lot of you may not feel comfortable or understand, okay? And it's really about advocating either for you or for your loved one.
Thanks, Jan. I suspect there are specific questions that people might have that could take you a little deeper on individual points. And so, thank you. We have a microphone that we can bring around. If you have specific questions about an issue related to navigating within the healthcare system, then please feel free to ask.
Okay, I'm just going to ask everyone to speak into the microphone so we can collect this as part of the presentation later on. Thanks.
A friend of mine's husband has had a stroke a couple years ago. She's at a point where she feels like she can't leave him. She has family around her and friends, but most of them are working and are not available. So, and he's involved with VA. So how do you deal with the VA and Medicare? And I believe he's on an Advantage plan at this point. So how do you deal with that?
Yeah. So it sounds like your friend's husband is at home and had a stroke, and it sounds like he possibly might have some functional deficits, and she's the primary caregiver. Here. See, the unfortunate thing is he probably doesn't require a level of care that either the VA or traditional Medicare would cover. And so that's a perfect example of the dilemma. What I can say, and Gary can speak to that maybe, as far as the respite and certainly the companionship or the additional home care support, that's what he and his team does. I could go into a situation like that and be able to assess the situation and talk about if the client would benefit from services at home that Gary would provide. I could also figure out what the VA would be required to provide. They're not going to offer it, I'll tell you that, not the VA. So there's always a solution to something. Is the client safe at home? Would the client be better off in a controlled setting, getting better medical and supervision? How is the caregiver doing? I'm sure she's burning out. Okay. And so we would look at the whole scope of what's going on. And if they really wanted to stay home, we would do everything possible to make it happen as long as it's a safe plan, okay? I got a call about a gentleman that is not on service with Gary because he couldn't pay out of pocket. And also he's stubborn and doesn't want to have anybody in the house, okay? So he's had, in the last 2 weeks, 2 hospital admissions. When he falls, he has to call 911 to be picked up. And there's a whole host of other issues, particularly around a major lower extremity wound that is grossly infected. So yes, he would be entitled to some wound care at home through his insurance, but if that starts to heal and he still has the same issues on taking care of himself, which he's not, it's just going to be a repetitive situation, okay? So he don't want to go nowhere. So what do we do? And again, this is kind of what I'm doing with the state as far as helping people to stay at home. So whether it's durable medical equipment, whether it's putting services in place a couple of days a week, safety checks. I mean, I've gone into homes to take a look at, how safe is the environment? And so there would be definitely an opportunity to be able to provide the support to her and then talk about what might be available.
So, ma'am, from a non-medical perspective, being able to provide her with some respite, some opportunity, a couple of hours a day for a couple of days a week, that may be all she needs to recharge her battery. I would look at two things. One is I would consider what Nest might be able to provide in terms of companionship, that someone could just sit there if he didn't need any services for a couple of hours, that she could go out. That would be one way. Or an agency like mine, where the flexibility is there to say, you'd like Tuesday and Thursday to have somebody come in for 2 or 3 hours, then we'll help provide that. But agencies will require a fee. They're the two places that I would look for the respite care, though.
Now, when Gary mentions going in a couple of days a week, we would anticipate something like a bathing, meal preparation perhaps, while the aide is there for, say, 2-3 hours. So they would do a whole host of tasks to, help the client on that particular day. And I have to say, the staff is outstanding, the clinical staff. Being a major skeptic here and watching everything, I have to say they do a phenomenal job in terms of helping clients at home and providing the services. Yes, ma'am.
I'm sorry, I have to get a little political here, but with all the talk about Medicaid cuts, Medicare cuts, how is that going to affect your work?
My work? My work? It won't affect my work. Okay. Now let me, and again, thank you for the question. It's a good question. Did you all hear the question about the cuts? I'm not quite sure yet what those cuts mean. And I don't think any of us do, really, at this point. But we are still entitled to Medicare. We are still entitled to the benefits. We still collect Social Security. If you're a Medicaid beneficiary, you are entitled to certain benefits. So the types of cuts that might be happening, I don't expect there to be any major impact on health care, okay? There'll be a tremendous amount of pushback in the constituency, I assure you. Other things might be cut that maybe are duplicative or don't add any value. But I think we don't want to get ahead of ourselves yet. Let's keep our eye on things and make sure that what does remain are the benefits, okay? So, does that answer your question?
It's going to add a lot of stress to people.
Yes, it will. It will add a lot of stress to people. All the more reason why you need someone to advocate for you, certainly. And this is a topic that is, Gary and I are very passionate about in terms of the caregiver and the caregiver support. We want to keep our loved ones at home. As you put up that statistic that over 90% of us want to remain at home. I live alone right now. I will tell you, my husband passed from pancreatic cancer 3 years ago. And I think about that. And I'm get a little personal. I may have to have some shoulder surgery, and I'm thinking, who's going to take care of me? Maybe I need to call Gary. I don't know. But the point is we all think about it. It's scary, okay? Who is going to take care of me? But I've already been on the internet and studying everything, so I'm not worried. I think I can advocate for myself. But I hope that I think we shouldn't get ahead of ourselves. Very good point, because there's a lot of scary things being talked about that. What do we believe? What should we believe? What are people telling us? And I say that it's way too premature and sometimes often inaccurate of the things that are going to get cut from my perspective. Yes, ma'am.
Yes, Could you give us an example of something that's Medicaid we would be entitled to through Medicaid? I'm more familiar with Medicare, but not Medicaid.
First off, to qualify for Medicaid, it's a financial criteria. I don't know if you know, but you can't really have more than $2,000 in the bank. You basically are poverty-stricken in order to qualify for Medicaid. And in fact, that gentleman I was talking to you about has a business, so and some assets, some liquid assets, and so he doesn't qualify for Medicaid. If he qualified for Medicaid, okay, which is, here's the irony, he would be a candidate for the program that I'm working with for the state. But you have to be a Medicaid beneficiary. And what does that do? It allows us to implement services in the home to keep the beneficiary in the home. Well, what happens to folks that aren't on Medicaid, like many of us aren't? Okay? See the gap in the disparity? So Medicaid will offer you your Medicare. If you're Medicare and Medicaid, your Medicare trumps Medicaid. So if you get sick and have to go in the hospital, your Medicare is covering and your Medicaid kicks in on everything else. If you needed care at home, skilled care at home, whether it be PT or nursing care for wound care, your Medicare would kick in, okay? Medicaid comes to play when you're looking at long-term care, and there's a whole other issue. If we don't qualify for Medicaid and we need long-term care and we don't have any other insurance, I don't have long-term care insurance, what do? Do you know how much a nursing home a month costs now? It's about $15,000 a month, $12,000 to $15,000 a month. I don't know what it is down here. Maybe someone else. Most of us don't have that kind of money, okay? So there's a huge disparity. That's why I say we want to capitalize whatever we can with the current insurance that we have. Squeeze it as much as possible. Not the impossible, not make something up that isn't there. I look for what's there and what you're entitled to, or your loved one. Yes, ma'am.
I know you're going to wait for me.
I'm sorry. I have a big mouth.
Not big enough.
So are you saying with Medicaid, what was that about $2,000? If they make more or less than $2,000, they do
Yeah.
or they don't
Yeah,
qualify?
one of the basic criteria is you can't have more than $2,000 in assets.
Oh, in assets. Oh, so if you own a home, a
No,
car,
not the home.
That's not
liquid
assets.
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 Yeah.
Gotcha.
Yeah,
You
there might be
qualify.
some Medicaid experts in the audience or
That's
that know
okay.
this inside and out. But you have to have no more than $2,000. Yeah, you have to spend down. Say you have $100,000 in your bank. You got to
Okay.
spend that down. What does that mean? You know, buying things that you need, perhaps a raised toilet seat, pressure relieving device for your chair. So you've got to spend that $100,000 till you get to $2,000. Okay, I had to do that with my mother. $300,000 had to be spent down before her Medicaid kicked in, and she passed away 2 days after it kicked in.
So
It's pretty devastating.
So I have
yeah.
another question. That wasn't really my question. It just hit me. So my question is, here a while back, I had a good friend who you talked about traditional Medicare, and I know the other one's the Advantage plan.
The managed Medicare.
Okay, so the managed. So at a certain facility, a couple had come into this facility who had the managed Medicare Aetna. They were denied. They said, we don't cover.
Into what facility?
It was an assisted living facility.
Okay.
In Brunswick County. I won't mention the name of it. But anyhow, so they were denied and sent away because they didn't have the traditional Medicare, but they had the managed Medicare Advantage plan of Aetna. Okay. And of another couple that was at the same facility while we was there with people that we had at the facility, also had Aetna, traditional. The facility turned them away and said, we don't take Aetna, period. So in the meantime, I've done a little bit of research. So when you speak of insurance, if this isn't like off of the subject here, I've got a thing here that I actually saved that I'm going to read. It says, a Medicare facility cannot refuse to accept a Medicare supplement policy. If it's a facility that accepts Medicare, it must also accept any Medicare supplement plan you have, as they are essentially, they have to follow the original Medicare coverage. But yet, a particular facility, whether you have traditional or managed, if it's Aetna, they totally refuse Aetna, but yet they accept Blue Cross, ARP, United, they accept the others. Is that legal?
So you got a couple of good points, okay? First of all, if it is indeed an assisted living facility, okay, versus a long-term care facility, Medicare does not cover care in an assisted living facility. For the care, for the $5,000 a month, say, it costs to stay in an assisted living facility. What they would cover, sticking on Medicare, is if the client needed to have any home care services, of like physical therapy. Medicare would cover that under the outpatient benefit. Now, you're absolutely right. What she read is that the supplement, mainly if it is a certified Medicare facility, in other words, they are certified and required to take Medicare beneficiaries. They go through criteria and they have to, So it's a certified Medicare facility. No, they cannot deny admission unless it's not medically necessary. Now that, in the assisted living environment, they don't cover it. Medicaid in North Carolina does pay a fee for certain levels of care less than skilled, like assisted living. There is some money that can go towards assisted living, and sometimes these, like a group home environment, Medicaid would cover. And then the other scenario is, they said they don't accept Aetna, right? You said? Yeah. Yeah. Only they cannot, well, first of all, Aetna or even traditional Medicare would not cover care in an assisted living facility. It's just not in the benefit structure.
Well, it covers for the same person who had Blue Cross Blue Shield, and it also covered, the facility also covered for the same person, for a different person who had, I think it's United Healthcare through ARP.
Yeah. The feds have a different, there's different levels of care in legislatively. So without really knowing, are they licensed as an assisted living facility? If you're licensed as an assisted living facility, there is no insurance that would cover it that I know of except Medicaid, okay? If it's licensed as a skilled nursing facility, all right, and the beneficiary was denied because of Aetna and they had Medicare Prime, that would not be cool. That would be a problem. I would challenge that.
Well, I wouldn't challenge it, but they are under investigation due to
Denials? Yeah. Yeah, there's more. It sounds like there might be some more to the story as far as, the decision making. If I was involved in a case like that, I would catch them. I would figure it out. But then also to help explain it to you, because it's too confusing. I'll get all the information, I'll do the dialoguing with the administrators, and then I would be able to explain it. So then maybe I'd have several more questions about the type of facility and the licensure. That's how they go by.
Hey, can you wait for a second?
If a person has some dementia, but otherwise is living in their home, capable of taking care of themselves and feeding themselves and such, but they can't, the dementia is stalling them on medication. They aren't taking their medication correctly, don't know what medication they're taking, don't take it sometimes. What kind of help would there be so that they could stay in their home but help them with their prescriptions?
So it sounds like the client may not be compliant with taking the medication. Okay. Does the client dispense their own medication, or someone okay, not the caregiver? There is, okay. That's even more dramatic. Okay, but marginally dementia, just good enough to remain at home but needs support. That's where we would, if I got a phone call like that and I would do an interview, I would probably pull Gary in and talk about the benefit of some additional in-home caregiver support. I would work in tandem with Gary to see about capitalizing on the existing insurance benefits to see that's the whole other thing. How many in the audience have long-term care insurance? Oh, I better get it. Ooh.
Wow.
Wow. Geez, I never, I did have actually a good experience with one client with her long-term care insurance. They ended up paying, but the poor thing had to jump through hoops, getting paperwork, medical records. So, again, I could help with that because sometimes it's ridiculous and sometimes, it's overkill. And we did run some interference together on that situation. But
we also help with long-term care insurance in that, like most insurance companies, they're reluctant to part with their money. And the hardest part is getting all the paperwork together and getting it submitted. So I have a member on staff who does that for each of our clients. And so there can be assistance provided for claiming your long-term care insurance. I'm surprised at the percentage of people here who do have long-term care insurance, because that's a much greater percentage than I've experienced in the general community. And so I urge you to take advantage of it when you can get the process started, because there's always a 60 or 90-day period up front before they'll start to pay. So, and during that 60 or 90 days, you take as little support as you can, so you pay as little as you can until you get through that 90-day period, and then you take all the support that you possibly need, and the insurance company pays for that. So there are ways that we can assist you in that. Gentleman up the back.
Just remember, tell them about the ADL to qualify for long-term care.
Well, long-term care insurance, thank you, Elliot. Long-term care insurance.
What was the question? Sorry. Could you say it again? Sorry.
Is there not two activity daily living ADLs required for long-term to kick in for that individual?
So the rules for a long-term care insurance company to be willing to pay, they require certain activities that you, the client, are not capable of doing, that the caregiver does for you. And that has to be specified every time a claim goes in, You know, my caregiver helped with bathing, helped with toileting, helped with feeding, whatever the activities of daily living that the original assessment, the insurance company does an assessment of the client, and they'll list those activities. We do an assessment of the client so that the caregivers are aware of what activities needed to be completed each time they attend, so that the claim doesn't constantly get rejected. So thank you for that point. It just clarifies, I think, the importance of knowing the rules that Jan is talking about in all aspects.
It also made me think about balancing long-term care with skilled care. You know, what should your insurance be paying for? The scenario that Gary had put up, which was there was a dichotomy between the long-term care insurance and the skilled nursing insurance from the Medicare, when Medicare should pay and when your long-term should kick in. Okay. Unfortunately, unless you are able to differentiate and ask the questions or challenge the issue, you know, it could come out of the long-term care benefit pool unnecessarily. Sir? Oh, this, okay.
I'm sorry. I have a quick question. How do we reach out to you? Through Nest or?
You would reach out to me through Gary at the No Place Like Home Caregivers.
No Place Like Home
Yes,
Caregivers
ma'am.
for Gary. Okay.
Yes, ma'am.
Yeah.
There was a couple other questions, sir? She's coming with the microphone.
Is this on? Yes. I was a primary care physician for many years and frequently dealt with the issue of what's medically necessary. And it's a vague term purposely so that the insurance company can choose not to pay. They're a fiduciary for the stockholders. They're not a fiduciary to the patient, except if you are a retired federal employee live in California. But I had the example of going into the hospital in the middle of the night to admit someone who couldn't breathe. And I, at that time, had to call the insurance company to get permission to admit them to the hospital. So I finally got someone on the phone, and they said, well, what's the problem? And I said, he has angioneurotic edema. And they said, well, we don't allow hospitalizations for neurosis. And I said, it's not a neurosis, it's an allergic reaction closing his windpipe. Yeah. And the next question was, how do you spell that?
Okay, wonderful example. Thank you, sir. Thank you, doctor.
But
Very
I
much.
think that's why we need help from you, not because you're threatening to come down there and beat them up, but because they're not knowledgeable. Yes.
You wouldn't believe some of the front-end folks that you'll connect with calling your insurance company, which I always end up talking to the top dog. I just kind of have to bypass it because there's just too much inexperience on the front end. And they are, as the doctor pointed out, have rote responses maybe, okay? And so I see that all the time. That he gave a perfect example. It goes to show with some radiology. I'm sure you experienced it with when you wanted to order a CAT scan for the brain. He must have gone through hoops to try to get authorization because he thought his patient had a brain tumor. Okay, so no, it goes on, which is really fundamental to my passion. I've seen too much of it, as you have, doctor, I'm sure, over the years. Thank you. Ma'am.
I have family members who don't live here in North Carolina. They live in California. They could very much use your services. How can I find someone like you who is reliable and honest in the area where they live?
As I said earlier, there are private care management agencies, okay? I can't speak to what their fee schedule is, but what the basic understanding that I have is they're quite hefty. But you would have you could find them, but that you would have to research the internet in the area, say it was San Francisco, private care management nurses or something like that, and they'll pop up. You'll see them in Florida, right? And so it's really a matter of connecting and getting a sense about their trustworthiness, their knowledge base, their competency, their commitment. There's no central, what is it? I'm certified. Yes, I'm certified as an accredited care manager across the nation. There are certifications, but I know plenty of case managers that I've worked with that don't have a certification, but they have years of experience. I got it because it was the cool thing to do years ago, so I kept it sounded important, you know. But I rely totally not on that. It's just what I've been exposed to and what I've been taught, you know, what I've observed. Yes.
I wondered if you have had any experience with this. My husband and I do not have children. We have nieces and nephews out of state with very busy young families. And so we are looking at changing our trust from having them be the contacts for healthcare, POA, and I've recently, I mean, you know what I mean, to make medical directions. I recently talked with somebody who is a physician in this area who is offering a service to be the healthcare power of attorney for a fee. Have you any familiar experience with that?
The only thing that I've heard of is these boutique primary care physician providers where you pay out of pocket. I'm sure there's a fee for that, and you don't need a physician or a nurse, for that matter, to become the healthcare power of attorney. Is that what you were saying, the healthcare power of attorney? Well, you can go through some, attorneys will do that. They will become, if you don't have any family member or close friend that you could trust or feel comfortable with assigning healthcare proxy or medical power of attorney, because that's what it is. You have, we create our advance directives, what you would do if you had what your wishes are in the end. You have a healthcare proxy, which you have to do for North Carolina. It doesn't go national. You have to do it here. Then you have the financial power of attorney, okay? So those have to all be assigned by whoever. You know, if it's your family member, your niece, you could assign that to anyone. I would, if I was going to go to someone like a physician or an attorney, I would be best to ask what their fee schedule was. Yes, sir.
When you're hospitalized and they make a determination that you need skilled care, normally the hospital will send you to the social worker in the hospital to set that up. So what's your experience here in the Wilmington area with the staff at the hospitals at the social level in helping patients get the right care relative to Medicare or the Advantage plan or whichever? Can you trust them in making those types of recommendations as you're discharged from the hospital?
Very good question. I don't know. I would say that there are some good discharge planners and there's some lousy ones, okay? And again, part of what we do is to, if, for instance, what I would also do, just as a scenario, is if there was a client that was in the hospital and needed to go to a skilled nursing facility, part of what I would do is to be sure that where they're recommending, it's easy for them to say, well, this facility has beds. Well, that might not be good enough. You know, maybe they have a poor quality rating. You cannot be forced out of the skilled nursing facility if, one, the facility they're recommending is greater than 25 miles away from your home, or if they are, no, that's it, 20. Other than that, you can refuse. The managed care companies can terminate your benefits if they find a suitable facility. That's going to take some appealing. That's going to take some pushback with the managed care company. Medicare is the same way. They could terminate your benefits if a suitable facility within a 25-mile radius from your home is found that's Medicare certified. You don't have to accept it. You don't have to move your loved one, but always be wary of the termination of benefits, and then you're on the hook, where they would balance bill you for care and continued care in the facility.
So to add on to that, you're sitting with the social worker, and she's recommending facility A. At that moment in time seems to be where you need to know whether facility A is a good facility as opposed to a adequate or substandard facility, so you could then challenge the social worker. So how do you get that information prior to getting through the whole, because once the social worker says go to facility A and you say, sure, you're there, and then moving from there, if it's inadequate, it becomes a bigger issue.
We're required to give you choice. And the standard practice is to give you 3 facilities, okay? Not the day of discharge. They are required to be doing a proactive discharge plan with the patient, okay? If they're doing this last-minute stuff, that's not right, okay? They have to give you some time. But they're required to recommend 3 facilities. Now, you may look at the 3 facilities and feel they're all trash. I don't want my loved one going there. You may have an issue. Unfortunately, that's the reality. If there was a Medicare certified facility, again, within a 25-mile radius that they found for you with an available bed, Medicare or even the managed care companies expect you to accept that bed. Hence why I was at the nursing home for my mother every day to keep an eye on things. And that's the unfortunate truth. Now, many of you can't be doing the legwork like that. And again, that's part of what I would do, is to set up a schedule and an interface with the long-term care facility. So it's not just skilled nursing that I would be involved with making sure the patient's getting the therapies, the wound care, whatever. It's really if the client is in long-term care, because that all counts. I mean, just because your loved one went into a long-term care facility, we want them to be taken care of with dignity, okay? And I've seen some really poor care that I had to challenge, only because I knew what I was talking about, and I was right. So a lot of people are stressed, and you hear more stories about folks, oh, the care is terrible or this or that, and we can't fix the whole thing, but we sure as hell can be working with our own loved ones and setting up some boundaries. Sir?
Is there a skilled facility? Is there a skilled facility rating organization that you could find and do some preliminary looking before you get involved?
So there's star ratings, and again, the internet. But Medicare does put out a manual. So facilities, say in the Brunswick County area, should be available to you and given to you by the discharging hospital. Okay, there is a manual, and they update it. So if you're in Brunswick County and you're looking for an extended care facility in Brunswick County, there is a manual that you should, it's a handbook for Medicare beneficiaries. You should ask about that. The second thing you can do is just Google the facility. There'll be a star rating, a Medicare star rating, because they get reviewed by the Joint Commission, okay? And they're rated. So that is disclosable on the internet.
So, sir, you mentioned, you asked a question about the quality of the social worker at discharge. And I'll refer back to this case study where there was a discharge plan put together by the facility, and it was only when someone like Jan, and Jan in this case, reviewed that discharge plan did she say that's inappropriate, it's inadequate, and she was able to argue a different plan. So again, it's a matter of timing. You get a little time up front. You get a few days when the planning should be underway, that you could engage somebody with a phone call, like Jan, to say, hey, could you help me out with this? Here's the situation. Jan would look at the physical issues. She'd look at the recommended plan for you, and perhaps come back with some other suggestions you could take to those meetings. So that becomes a timing, getting ahead of it rather than waiting until you get caught in a facility you don't like.
Yes.
This was 11 years ago, so things have probably changed drastically. But short story. My husband was in the hospital, and I needed to go into a rehab facility. There was one very close to the hospital, and it had a 5-star rating. And I thought, this is wonderful. And I was not told until after he left there a month later that they were in the process of selling the facility, and nurses were leaving. They did not have enough nurses. So to my way of thinking, they went from a 5-star to maybe a 1-star, because he would push the button and not
Nobody
get a
came.
response for at least an hour or more.
Yeah.
And you can't always trust those ratings.
Yeah, no, and very good point. I think she makes an excellent point of, how clear are the ratings. And I have to tend to agree with you. You cannot, put all your eggs in one basket because it's got a 5-star rating. The real thing is visibility, showing up. And you may not be able to do that. So you would assign that. You would delegate that responsibility. Even once a week to go in. I want to see the care plan. I want to know, let's have a meeting. I'd coordinate the meeting. I want to know how he's been doing. Is he getting, range of motion exercises? How's he doing with his medication? When did the facility doc last see him? I want to see the progress note, because we want to keep them well. There's nothing worse than inactivity. I should talk. You're in a long-term care facility and you go from the bed to the chair all day, sitting there. I mean, we know the horror stories. We've seen it, okay? And those are the things we critically look at. So it's not the end because they're in a long-term care facility. They have an obligation, and we expect high-quality, cost-effective care, but that they need the attention. So no, you're right. I think I have to agree with her that I would dig a little bit deeper. And we don't have a crystal ball, so we really don't know until they get in there. And I got my mother into that facility because I knew them, and I figured, well, I'm networking here. But I'll tell you, I caught them doing some really substandard care that I feverishly addressed. Medication administration, all sorts of things, so.
One more?
One more short one, because we do have to give up the meeting.
We could talk all night. Did anybody bring wine?
I'll try to make it short. I appreciate you being an advocate for us with insurance companies and the services. What interaction do you have with our doctors?
The same thing. I would, as long as I have a authorization to appoint document, they would be required, the physician's office, whether it's a nurse practitioner, which is fine by me, as long as they know the client, so I can talk clinically about what I'm seeing, what they're recommending, what we can put in place. So it's any provider that Gary put up there that I would have, with permission, to speak with. So I'd be lucky if I got the physician, unless it's one of those special physicians that, is, committed to talking with family and keeping family involved. But yes, I would have that, ability to do that.
I want to thank Jane and Gary. Jan, I'm sorry.